Okay, everybody, Dr. Rafich here from Vet Triage. Monday, January 13, 2025, 10:39 a.m. Pacific time. We are going through this October 2024 edition of Veterinary Surgery, and it is this paper out of Italy. Laparatomy-assisted endoscopic removal of gastrointestinal foreign bodies, the evaluation of this technique, and postoperative recovery in dogs and cats. The objective is to compare the outcome of laparotomy-assisted endoscopic removal of GI foreign bodies with traditional enterotomy and determine which factors affect the ability to remove foreign bodies. Retrospective study in dogs and cats, total of 81 animals. They divided the dogs and cats into two groups. Group 1 was the laparotomy-assisted endoscopic removal, and Group 2 was the enterotomy group. The results show that the endoscopic removal allowed complete or partial removal of foreign bodies in 35 out of 40 dogs and cats, regardless of the characteristics or location of the foreign bodies. The presence of intestinal wall damage was associated with conversion to an enterotomy. The endoscopic group required a shorter postoperative hospitalization stay, less need for analgesia, and experienced a faster resumption of spontaneous feeding, and had a similar complication rate to the enterotomy group. Introduction. In human medicine, age, location, size, and longer impaction time are known risk factors. Major complications after enterotomy are uncommon, with wound dehiscence and septic peritonitis in 2 to 12% of cases. Death is rare and observed in 3% of cases. Laparotomy-assisted endoscopic removal of gastrointestinal foreign bodies is a combination of exploratory laparotomy with endoscopy, providing direct access to the foreign body and allowing safe removal without an enterotomy. The effectiveness of 43%, meaning animals not receiving enterotomy, only a few minor postoperative complications, 8%, namely wound discharge and mild esophagitis. For the materials and methods, study design and inclusion criteria. These are cases from 2010 to 2023. Abdominal radiographs and/or ultrasound was used for diagnosis. The endoscopy group included all dogs and cats with evidence of foreign body in the stomach and pylorus, duodenum, jejunum, and in which case the scoping was applied or attempted. The enterotomy group are all the animals where surgery was performed and at least one enterotomy was performed without any endoscopic attempts. The intraoperative and short-term complications were classified according to the Veterinary Cooperative Oncology Group common terminology criteria for adverse events, with a grading system ranging from 1 to 5. For the Group 1, which is the endoscopy group, they divided into subgroups where it was completely effective in removing the foreign body, meaning there were no intestinal or gastric incisions needed. Subgroup B, partially effective, meaning at least one intestinal incision was needed. And then Group C needed to convert over to enterotomy. In regard to surgical technique and perioperative management, these animals received some combination of methadone, fentanyl, or butorphanol, alone or in combination with dexmedetomidine or ketamine, propofol or alfaxolone for induction, isoflurane for gas anesthesia with oxygen, and then fentanyl, lidocaine, or a combination. Antibiotics were ampicillin, sulbactam, or cefazolin, and then post-op methadone or buprenorphine, post-op GI protectants like esomeprazole, and antiemetics like mirapatent, and prokinetics like metoclopramide, as well as enteral feeding by nasoesophageal or nasogastric feeding tubes. In selected cases, these are all case dependent. Technique for the endoscopy group, they used flexible endoscopes, and they assessed the possibility of moving the foreign body into the stomach from the intestines, and if that was possible, then it was followed up with endoscopic removal. Laparotomy-assisted endoscopic removal was excluded if there were any signs of intestinal non-viability present orally to the foreign body or at the level of the loop involved. Once the foreign body was removed, the esophagus, stomach, duodenum were explored with the scope, carefully avoiding overinflating the gastrointestinal tract. Results. 40 of 81 cases were enrolled in Group 1, the endoscopy group, mostly male-neutered or female-spayed. 41 of the 81 cases were in the enterotomy group, mostly males. And then as far as breeds go, for the scoping group, most of them were Labradors, English Setters, and Dachshunds. And then for the endoscopy group, mixed breed dog, Dachshunds, Labradors. The median age of the endoscopy group was 51 months, and the median weight was 18.6 kilograms. I don't like this trend of using months for the age. It's just so stupid. Just convert it to years, you know? Median age of the enterotomy group was 65 months for dogs, and the median weight was 19.1 kilograms. Most of the cats were domestic short-haired cats. Median age of cats was 27 months in the scoping group, and median weight is 4.5 kilograms. And then in the enterotomy group, mostly domestic short hairs, median age 6 years. Oh, look, 6 years. Wow. I mean, when do they not use months? Like, what's the cutoff? You know? Just go with years. And the median weight was 3.9 kilograms. Okay, for the scoping group, the symptoms had appeared in a median of 24 hours before surgery, mostly vomiting and then problems with eating. In the enterotomy group, signs were reported a median length of 48 hours. In the scoping group, 31 of the 40 foreign bodies were blunt, 9 were sharp, 27 of the foreign bodies out of the 40 were single, 13 were multiple, 25 were linear, 15 were discrete. I wish they would convert these to percentages in these studies. Percentages mean more than absolute numbers. Enterotomy group, the foreign body was blunt in 10 out of 39, the rest were sharp. 6 were linear, 35 were discrete, 37 had a single foreign body, and 4 had multiple. The main localization of the foreign bodies in the scoping group was stomach to jejunum in 24 cases out of 40, followed by duodenum in 6, jejunum in 6. And then for the scoping group, 10 out of 40 dogs and cats had ileus postoperatively. And then after that, it was superficial surgical site infection. 1 dog had pancreatitis. In the enterotomy group of dogs and cats, post-op complications occurred in 18. 3 of them were multiple complications. Overall, 12 out of 41 developed post-operative ileus, and 2 out of 41 developed grade 3 aspiration pneumonia. And then regarding laparatomy-assisted endoscopic removal, 35 out of 40 cases, it was considered completely or partially effective in removing the foreign body. In the scoping group in dogs and cats with intestinal wall damage, the scope did not affect the development of short-term postoperative complications. However, the intraoperative findings of intestinal wall damage was associated with need for at least 1 surgical incision involving the GI tract. Furthermore, in the scoping group, when comparing to subgroup A with subgroup B and C, so these are the ones that either did not need any incision or needed 1 versus multiple, like a conversion, no difference was noted in terms of post-op short-term complications or a presence of post-operative ileus. In the scoping group, dogs and cats with the scope was effective for removal of all foreign bodies, meaning subgroup A. They had a shorter length of hospitalization, less need for analgesia, and a shorter resumption time to spontaneous feedings. This was compared to dogs and cats, where they at least had 1 intestinal incision, so subgroups B and C. Finally, when comparing both groups, no differences were noted in terms of age, weight, intraop complications, postoperative short-term complications, and the presence of ileus postoperatively. Discussion. A reduced need for analgesia, a shorter hospitalization, and early resumption of spontaneous feeding was observed with scoping, regardless of whether it was partial or completely effective, when compared to those that had the traditional gastrointestinal surgery. The early enteral feeding in critically ill dogs and cats, especially after GI surgery, is beneficial. Physiological effects, reduces oxidative damage, decreases ileus, decreases bacterial translocation, increased wound healing, and generally improving outcomes. Although enteral nutrition could be ensured through feeding tubes like nasoesophageal or nasogastric tubes, spontaneous food intake is commonly preferred over because of its positive effect on post-op recovery. The scoping technique did not result in a lower incidence of post-operative complications, specifically post-operative ileus, when compared with dogs and cats who only went enterotomy. This result may be explained by the fact that the pathogenesis of post-op ileus is multifactorial. Anesthesia, opioids, manipulating the GI tract all contribute to the possibility of ileus, even without incising the GI tract. The scoping technique resulted in a lower incidence of major complications, meaning grade 3 and grade 4, using that grading system they had, and it was only reported in one dog in the scoping group. The risk of wound dehiscence, especially in the case of low protein ileus and enteric dysmicrobism, could lead to septic peritonitis, 2 to 12% incidence, and can be fatal. It can be speculated that the scoping technique may require longer in comparison to traditional techniques, but another study reported the opposite. These could be related to operator experience, and there's a learning curve for it. Once technique has been learned, the surgical time may be shortened, and this could be particularly beneficial in unstable cases when there's a higher risk of post-op complications. In dogs and cats with intraoperative findings of intestinal wall damage, which were treated with scoping, did not have more post-op complications when compared to others. However, this is associated with the need to perform at least one enterotomy. The gastrotomy, as compared to enterotomy, could lead to fewer complications and a lower risk of dehiscence, especially with intestinal damage. Finally, this procedure is easy and offers advantages of a clean over a clean contaminated procedure, avoiding the risk of intraoperative abdominal contamination and reducing the risk of post-op wound dehiscence and septic peritonitis. The disadvantage of this technique are that specialized equipment such as scoping is required, and in addition to the surgeons, the presence of another operator who deals only with the scope is necessary during surgery. So the picture you have below is a standard tower that we use for scoping, and so you can see all the equipment needed for that. Number 1 there points, number 1, 2, 3, 4, that all points to the scoping itself, the fiber optic tube, but the rest of it is all the TV monitors and controls for that. So it takes up a lot of space, and it's also very expensive. Secondly, you need to have 2 people at least involved, 2 doctors anyway. One is the surgeon involved with actual surgery, and the other person is the doctor that's manning the scope. Complication or issues with this paper is, we always want more animals, of course, and it'd be nice to have long-term follow-up with them. But it's cool to see that we are combining minimally invasive techniques with more invasive techniques, and that's actually improving the post-operative stuff like analgesia and hospitalization stay. Usually it was considered all or nothing. Either you do scoping and that improves those factors, but you're limited, or you do surgery, which is not limiting in most cases, but results in longer times to eating, more pain meds needed, and more hospitalization time. All right, guys, we'll be back tomorrow. Thanks to those who support us, and we'll see you then. Bye.